Every single day, people sit in my office and tell me their blood pressure is fine. They had it checked once, maybe twice, the number looked reasonable, and they moved on. Meanwhile, inside their body, a slow, silent process is already deciding how their story ends, not whether they get sick, which disease gets to them first: heart attack, stroke, kidney failure, dementia. Blood pressure does not just indicate risk, it is the single most accurate predictor of how your body will eventually break down. And the tragedy is, most people have no idea what their numbers actually mean, which number matters more, or that the most dangerous blood pressure pattern is the one that feels completely normal. You walk around, you feel fine, you assume everything is fine. It is not. Your arteries are under pressure right now, this second, and that pressure is either protecting your organs or quietly destroying them. There is no neutral. Subscribe and hit like right now. What you are about to hear, nobody is going to explain this clearly at your next checkup. The system profits when you stay on medication, not when you understand what is actually happening. Help Dr. Johnson reach 100,000 subscribers. Every single one counts. So let us start with the basics, because almost everyone gets this wrong. Blood pressure is not one measurement. It is two, and they tell completely different stories about your cardiovascular system. The top number, systolic pressure, is the force inside your arteries at the exact moment your heart contracts and pushes blood out. Think of it as the peak impact your vessels absorb with every single heartbeat. Roughly 100,000 times per day, your artery walls take that hit. The bottom number, diastolic pressure, is the pressure that remains in your arteries between beats, when the heart muscle relaxes and refills with blood. This is the baseline tension your vessel walls live under 24 hours a day, even while you sleep. Most people fixate on the top number because it is bigger and more dramatic. That is a mistake. After 50, the relationship between these two numbers shifts in ways that completely change what your risk looks like. The gap between them starts to widen. That widening gap has a name, and it carries consequences that most people never hear about until the damage is already done. We are going to cover that in detail, but first, a quick note. A lot of you have already been checking out Care Health, the link on my channel page, and it has been blowing up lately. If you have not looked at it yet, it is right there on the channel page. Now, back to the numbers. Here is where it gets dangerous. You have been told your whole life that 120/80 is the gold standard, the perfect number. Anything close to that, and you are fine. After 50, that guideline can mislead you in a way that costs you years of your life. Here is what happens. As you age, your arteries stiffen. The walls lose elasticity. They become less like flexible rubber tubing and more like rigid plastic pipes. When that happens, your systolic pressure, the top number, climbs, but your diastolic, the bottom number, can actually drop. So you sit in a chair, the cuff inflates, and you see 145/70. Your first thought is, not great, but not terrible. Your doctor may even say the same thing. In reality, that reading is a red flag. The gap between the top and bottom numbers is called pulse pressure. In that example, the gap is 75 points. A healthy pulse pressure is roughly 40 to 50. When it stretches beyond 60, you are looking at a direct marker of arterial stiffness. And arterial stiffness is not cosmetic, it is mechanical. Here is the physics. A healthy elastic artery absorbs the shock of each heartbeat. It stretches slightly when blood surges through, then gently recoils. That cushioning effect protects the smaller, more delicate vessels downstream, the ones feeding your brain, your kidneys, your eyes. A stiff artery cannot do that. It passes the full force of every contraction straight through, unfiltered, like a hammer hitting a nail with no padding. 100,000 beats a day, every single one slamming into the fragile vessels of your most vital organs. That is the mechanism behind the strokes, the cognitive decline, and the organ damage that seemed to appear out of nowhere in people whose blood pressure looked manageable on paper. Many doctors still treat the top number in isolation. They bring systolic down with medication and consider the job done. Pulse pressure as its own independent risk factor is rarely discussed with patients. If nobody has ever calculated yours, you need to do it yourself. Take your top number, subtract the bottom. If the gap is above 60, that conversation with your doctor cannot wait. When people think about blood pressure damage, they think about the heart. That is understandable. It is the organ doing the pumping. But the first organ to fail from sustained high blood pressure is almost never the heart. It is your kidneys. and they fail silently, without a single symptom for years before anyone notices. Here is why. Your kidneys filter your entire blood volume roughly 40 times every single day. That is not a typo. The blood enters the kidney through a large artery that branches into progressively smaller vessels until it reaches structures called glomeruli, microscopic clusters of capillaries, so fine you cannot see them without a microscope. These are the filters. Each kidney contains roughly 1 million of them, and they are extraordinarily delicate. Now picture what happens when the blood arriving at those filters is under excessive pressure, day after day, year after year. The delicate walls of the glomeruli take damage. They thicken. They scar. They lose their ability to filter properly. Waste products that should be leaving your body begin to accumulate. Proteins that should stay in your blood start leaking into your urine. And you feel absolutely nothing. No pain, no burning, no obvious sign whatsoever. By the time kidney damage shows up on a standard blood test, specifically through elevated creatinine levels or a dropping GFR, which stands for glomerular filtration rate and measures how efficiently your kidneys are actually filtering, you have already lost roughly 50% of your kidney function, half of it gone, before a single symptom appeared. That is not a slow decline you can catch early with intuition. That is a silent collapse. And the cruelest part, kidney damage and blood pressure form a vicious loop. Damaged kidneys lose their ability to regulate fluid and sodium balance, which drives blood pressure even higher, which damages the kidneys further. Once that loop starts spinning, it accelerates. This is exactly why blood pressure is not just a heart issue. It is a kidney issue, and nobody explained that to you at your last appointment. Most people assume the danger is a high number that stays high. If their blood pressure is consistently elevated, they understand there is a problem. What almost nobody knows is that fluctuating blood pressure, the kind that swings up and down throughout the day, is its own independent risk factor for brain damage. And in many cases, it is worse than a number that is steadily elevated. Let me explain the mechanism. Your brain is fed by some of the most delicate arteries in your entire body. These vessels are designed to operate within a narrow range of pressure. When blood pressure spikes sharply and then drops, then spikes again, it creates a phenomenon called shear stress. That is the mechanical force of blood slamming against the inner wall of the vessel and then pulling back. Repeated shear stress tears at the endothelium, the microscopically thin inner lining we discussed earlier. Over time, this produces small areas of damage deep inside the brain called white matter lesions. These are tiny zones where nerve fibers have lost their insulating coating because the blood supply was disrupted. They do not cause a dramatic event. There is no moment where you collapse or lose function. Instead, your thinking slows down, your memory becomes unreliable, your ability to focus erodes gradually. You blame it on age, on stress, on poor sleep. In reality, it is structural damage to the wiring of your brain caused by pressure that keeps swinging. Research now shows that blood pressure variability is an independent predictor of dementia, separate from average blood pressure. Two people can have the same average reading over a year. The one whose pressure swings wildly from morning to evening will show significantly more brain shrinkage on imaging than the one whose pressure is stable. This is why a single reading at a doctor's office tells you almost nothing about your real risk. One snapshot, one moment in time, in a room where your body is already stressed. It misses the full picture entirely, and that full picture is what your brain depends on. Here is something that should concern you. Everything we have discussed so far, the stiff arteries, the kidney damage, the brain lesions, all of it accelerates during a specific window of time that nobody is monitoring, nighttime. While you sleep, your blood pressure is supposed to drop. This is called nocturnal dipping. In a healthy cardiovascular system, blood pressure falls by roughly 10 to 20% during sleep. Your heart slows down, your vessels relax, your organs get a period of genuine rest and recovery. That dip is not optional. It is a critical part of how your body repairs itself. Now here is the problem. In a significant number of people, especially after 50, that dip does not happen. Their blood pressure stays flat through the night, sometimes at the same level as during the day. Doctors call these patients non-dippers. And in a smaller but extremely high-risk group, blood pressure actually rises during sleep. Those are reverse dippers. The clinical data on these patterns is alarming. Non-dippers have significantly higher rates of stroke, heart failure, kidney deterioration, and sudden cardiac death compared to people whose pressure drops normally at night. Reverse dippers carry even higher risk. Their organs never get a break. 24 hours a day, 7 days a week. the pressure keeps grinding. And here is what makes this genuinely dangerous. You cannot detect this pattern with a standard office visit. You sit in a chair. The cuff goes on. The doctor gets one number at 2 o'clock in the afternoon. That reading tells you nothing about what happens at 3 o'clock in the morning. The only way to see the full picture is ambulatory 24-hour blood pressure monitoring. You wear a small cuff for an entire day and night. It inflates automatically every 15 to 30 minutes and records every reading. The device captures your daytime pattern, your nighttime dip or lack of one, and your early morning surge, which is when the majority of heart attacks and strokes actually occur. Most patients have never been offered this test. Many have never even heard of it. If you are over 50, if you have any history of elevated blood pressure, if you snore heavily or have been told you stop breathing in your sleep, ask your doctor directly about 24-hour ambulatory monitoring. Do not wait for them to suggest it. That suggestion may never come. If there is one piece of dietary advice every person with blood pressure concerns has heard, it is this: eat less salt, cut the sodium, put down the shaker. It sounds simple and definitive. The reality is far more complicated, and the oversimplification has caused millions of people to focus on the wrong thing entirely. Here is what the research actually shows. Roughly half the population is what scientists call salt-sensitive. In these people, sodium intake has a direct, measurable effect on blood pressure. More salt means higher pressure. Less salt means lower pressure. The mechanism is real and significant. But the other half, roughly 50% of people, are salt-resistant. Their blood pressure barely moves regardless of how much sodium they consume. Their kidneys handle the excess efficiently, and the numbers stay stable. The problem is almost nobody gets tested for salt sensitivity. So you get a blanket recommendation that helps half the population and does essentially nothing for the other half, while the real dietary culprit goes completely unaddressed. That culprit is potassium deficiency. Potassium is not a nice extra. It is a direct physiological counterbalance to sodium at the cellular level. It relaxes the smooth muscle in your blood vessel walls. It signals your kidneys to excrete excess sodium more efficiently. It is one of the most powerful natural regulators of blood pressure your body has access to, and most adults consume less than half the recommended daily amount. The recommended intake is roughly 3,500 to 4,700 milligrams per day. The average adult gets about 2,000. That deficit is not trivial. It means your vessels are operating without one of their primary tools for staying relaxed and flexible. The best food sources are not exotic. Bananas get all the attention, but they are not even close to the top of the list. A single medium-baked potato with the skin contains nearly twice the potassium of a banana. Sweet potatoes, spinach, white beans, avocados, and plain yogurt are all significantly richer sources. Then there is magnesium, another mineral most people are deficient in. Magnesium works alongside potassium to regulate vascular tone. Low magnesium increases arterial stiffness, the exact problem we discussed in Chapter 3. And here is one that surprises almost everyone. Chronic low-grade dehydration raises blood pressure. Not dramatically, not overnight. But when your body senses that fluid volume is consistently low, it activates the renin-angiotensin system, a hormonal cascade that constricts blood vessels and tells the kidneys to retain sodium and water. The result is a slow, steady upward creep in baseline pressure, driven not by what you are eating, but by what you are not drinking. You are chasing salt out of your diet while your body is screaming for water and potassium. That is the mismatch nobody corrects at your appointment. Exercise lowers blood pressure. That is well established. Multiple studies confirm it. Walking, cycling, swimming, these activities performed regularly reduce resting blood pressure over time by relaxing vessel walls, improving cardiac efficiency, and enhancing the flexibility of your arterial system. That is dynamic exercise. Your body moves continuously, your heart rate rises gradually, blood flows smoothly, and your vessels adapt. But there is another category of exercise that can do the exact opposite in a matter of seconds. And most people have no idea it is happening. It is called the Valsalva maneuver. You know it even if you have never heard the name. You are lifting something heavy, a box, a grandchild, a barbell at the gym. You take a breath, you clamp your mouth shut, you bear down, and you push. In that moment, the pressure inside your chest cavity skyrockets. Your blood pressure can spike to 300 over 150 or higher. Briefly, explosively. In a young, healthy person with elastic arteries, the vessels stretch, absorb the surge, and recover. No damage. But after 50, when your arteries are already stiff and less compliant, when your vessel walls may already have weak points from years of plaque buildup, that momentary spike is not harmless. It is a trigger. A hemorrhagic stroke, where a vessel in the brain bursts, can happen in exactly that moment. An aortic dissection, where the wall of the body's largest artery tears from the inside, can be initiated by that single surge. These are not theoretical risks. They are documented clinical events. The distinction is not between exercise and no exercise. It is between exercise with proper breathing and exercise with breath holding. The correct pattern for any resistance movement is simple. Exhale during the effort, the push, the lift, the exertion phase. Inhale during the release, the lowering, the return phase. Never hold your breath against a closed mouth and throat while straining. That single correction eliminates the pressure spike. Your muscles still work. Your strength still builds. But your vessels are no longer absorbing a shock they were not designed to handle. If you exercise, this is not optional knowledge. This is the difference between exercise that heals and exercise that kills. If you take blood pressure medication, or if you have been told you need to start, there is something you deserve to understand. Not all blood pressure drugs work the same way. There are 4 main classes, and each one lowers your pressure through a completely different mechanism. The right class for your specific body can make you feel fine. The wrong class can make you miserable. And the difference often comes down to a conversation that never happens because the appointment ran out of time. The first class is ACE inhibitors. ACE stands for angiotensin-converting enzyme. Your body produces a hormone called angiotensin II that tightens blood vessels. ACE inhibitors block the enzyme that creates that hormone. Vessels relax, pressure drops. Common side effect, a persistent dry cough that drives some people out of their minds. It is not dangerous, but it is relentless, and many patients stop taking the medication without telling their doctor why. The second class is beta blockers. These slow your heart rate and reduce the force of each contraction. Less force, less pressure on the vessel walls. But beta blockers also reduce energy output. Some people feel exhausted, sluggish, or foggy. Athletes and active people notice it most. The third class is diuretics. These reduce the volume of fluid circulating in your blood by telling the kidneys to excrete more water and sodium. Less volume, less pressure in the system. The trade-off is frequent urination and potential loss of potassium and magnesium, the exact minerals we just discussed. Without replacing those, you can develop muscle cramps, fatigue, and irregular heartbeat. The fourth class is calcium channel blockers. Calcium triggers muscle contraction in artery walls. Block the calcium channels and the muscle relaxes. Arteries widen, pressure falls. Side effects can include ankle swelling, flushing, and dizziness. Here is the point. Each of these drugs does something different to a different part of the system. When a patient feels terrible on medication, it almost never means medication does not work for them. It means that specific class is wrong for their specific physiology. The tragedy is how many people quietly stop taking their pills, never report the side effects, and walk around with uncontrolled pressure because they assumed they had no choice. You always have a choice. Write down every side effect you experience. Bring that list to your next appointment. Do not wait for your doctor to ask. That list changes the conversation from "take this" to "let us find what actually works for your body." Medication adjustment is not failure, it is precision. Now, the most practical part of this entire video. I am going to give you 3 things you can do every single day that are clinically shown to lower blood pressure. No prescription, no equipment, no gym membership, just your body and a few minutes of attention. The first technique is slow diaphragmatic breathing, not the shallow chest breathing you do all day without thinking. Deep, deliberate belly breathing with a specific rhythm. Inhale through your nose for 4 seconds. Exhale slowly through your mouth for 6 to 8 seconds. The exhale must be longer than the inhale. That ratio is what activates your parasympathetic nervous system, the branch of your nervous system responsible for slowing the heart, relaxing blood vessel walls, and pulling your body out of a stress response. 5 minutes of this breathing pattern measurably reduces arterial pressure, not over months. In that session, do it daily, and the cumulative effect builds. The second technique is isometric hand grip training. Take a stress ball, a rolled up towel, or even a tennis ball. Squeeze it at roughly 30% of your maximum effort. Not a death grip. A moderate, sustained squeeze. Hold for 2 minutes. Rest for 1 minute. Repeat 4 times. That is 12 minutes, 3 times per week. Clinical trials, published peer-reviewed trials, show that this protocol lowers systolic blood pressure by 8 to 10 points over 8 weeks. That is comparable to what some medications achieve. The mechanism is vascular remodeling. The sustained moderate contraction triggers your arteries to adapt and become more flexible over time. The third technique is a 10-minute walk after dinner. Not a power walk, a slow, easy stroll. After your evening meal, blood sugar rises. That glucose spike triggers insulin release, which affects sodium retention and vascular tone. A short walk immediately after eating blunts that spike reduces the insulin surge and directly lowers the nighttime blood pressure rise that we discussed in Chapter 6. These 3 things are not replacements for medication. If your doctor has prescribed something, keep taking it. But these are physiologically proven tools that work alongside medication to bring your numbers down further. Or, if you are in that gray zone where your pressure is elevated but not yet medicated, these may be exactly what keeps you from crossing that line. This is the part most people never hear. Your age does not just increase your blood pressure risk. It fundamentally changes which number matters, which pattern is dangerous, and what treatment approach makes sense. In your 30s and 40s, the bottom number is the one to watch. Elevated diastolic pressure at that age signals that your smaller arteries, the ones deep in your tissues, are already tightening. They are resisting blood flow. That resistance is called peripheral vascular resistance, and it is one of the earliest markers of arterial disease. Your arteries are still flexible enough that the top number may look fine, but the bottom number is telling you the walls are already starting to squeeze. After 50, the picture flips. Your arteries stiffen. The top number begins climbing because those rigid vessels can no longer absorb the impact of each heartbeat. The bottom number may actually drop because stiff arteries do not recoil effectively between beats. Now, the critical marker is no longer systolic or diastolic alone. It is the gap between them, pulse pressure, which we covered earlier. A widening gap means accelerating stiffness, and accelerating stiffness means accelerating organ damage. After 65, a pattern called isolated systolic hypertension becomes the most common form of high blood pressure. The top number is elevated, sometimes significantly, while the bottom sits at 70 or even lower. This is where treatment becomes a tightrope. Aggressive medication that drives the top number down will inevitably push the bottom number down with it. And diastolic pressure below roughly 60 to 65 creates its own danger. Your coronary arteries, the vessels feeding your heart muscle itself, fill primarily during the diastolic phase between beats. If diastolic pressure drops too low, blood flow to the heart muscle decreases. You are protecting the brain from high systolic pressure while starving the heart of adequate diastolic flow. That is why medication in older patients requires precision, not just force. How old are you? Write it in the comments. I want to know which age group this material hits closest to home for, because your decade changes everything about what you should be monitoring, what your numbers actually mean, and what your next conversation with your doctor needs to include. Everything we covered today leads to one conclusion. Knowing your blood pressure numbers is step 1. Understanding what those numbers actually mean, the pulse pressure, the nighttime pattern, the kidney damage, the brain changes, that is step 2. But the step almost nobody takes is step 3. Actually getting evaluated, actually getting access to the advanced monitoring, the metabolic panels, the emerging treatments that exist right now but that most people never hear about because their 12-minute office visit ran out of time before the conversation even started. That is exactly why I want to tell you about Care Health. Care Health is a platform that connects you with clinical trials and innovative treatment options happening right now in your area. You fill out a short form, it takes less than 30 seconds, and you get matched with trials that are specifically relevant to your health profile. Hypertension, cardiovascular risk, metabolic conditions, the exact things we talked about today. These are not experimental gambles. These are monitored, structured programs run by real medical teams, and many of them offer treatments and evaluations you simply cannot access through a standard doctor visit. Advanced vascular assessments, 24-hour monitoring protocols, metabolic panels that go far beyond what a routine checkup covers. The kind of evaluation that can catch the silent damage before it becomes irreversible. Here is the important part. This is currently available exclusively to U.S. residents, and based on what I am hearing from the Care Health team, spots are filling up fast. Thousands of viewers from this channel have already signed up. and some of the most in-demand trials are approaching their enrollment limits. Once a trial fills, it closes. There is no wait list. That window is gone. If you are watching on a computer, open your phone camera right now, point it at the QR code on your screen, and tap the link that pops up. It takes 2 seconds. If you are watching on your phone, tap my channel profile picture. That takes you to the channel page, and you will see the Care Health link right there. A screenshot is appearing on screen right now showing you exactly where to find it. Do not put this off. You just spent this entire video learning how blood pressure silently determines your future. The information is in your hands. Now do something with it. The people who act on what they learn are the ones whose outcomes actually change. The ones who say I will look into it later almost never do. This will not be available forever. Take 30 seconds and check whether there is a trial near you. That is all it takes.